I'm Peter Worley. I'm originally born in Germany. I finished high school, went to business school, did a dental technician program, 4-year program in Switzerland before then did my dental education in the US, where I graduated from the Harvard School of Dental Medicine. I got advanced education program in prosthodontics and an advanced education program in implant dentistry. Currently, I'm in private practice in Newport Beach, California. It's not so much the laboratory support in the US of A versus the world. We have 3 or 4 countries, mostly Germany, Belgium, Switzerland, Japan, where we have excellent technicians. They go through an extensive training program. And then we have the rest of the world where we really don't have that education, which is a 4-year program plus a master's program, so it can be significant education. So clearly, we can be envious of our colleagues that practice in these countries, but realistically, we have to come to the conclusion that most of our technicians are not as good trained as we would like to have them. The new advances, especially with regards to pressable systems, make it possible for the average dental technician to deliver consistency, high quality, and aesthetics at reasonable price. So we took out the artistic part of the equation, and that where we had the biggest problem with inexperienced or not well-trained technicians, and substituted them with new technology. And I think that will enable even the average technician to predictably, consistently produce better than average restorations, which come very close to restorations they couldn't have dreamed of 5 years ago. The preparation design for laminates will ultimately depend on the indication. We have some patients where we just need very minimal preparation. We can basically stay in enamel, where they just either want to straighten out the edges, elongate the teeth a little bit, or change the color of their teeth. So there we use minimal preparation. On the other hand, we have teeth that are severely broken down, that are discolored, where in previous years we would have placed crowns on them, but because of advances in porcelain technology, now we're able to actually do minimally invasive preparations for these patients as well. And we will go to a glove crown or a 3/4 cup crown kind of preparation, because now we have substrate to support our porcelain even in the veneer application. The advances in aesthetic dentistry can be broken down into the fields where they're going to happen. Most importantly, I think dentists understand that if they supervise deterioration of their patients, it's going to be difficult to bring them back. So early intervention, I think, is a key portion, where we already know if we have continued bone loss that if we don't do anything about it, it only will get worse. Secondly, I think bone morphogenic proteins on implants will allow us to predictably grow bone in areas where we were not able to do in the past, and that then will allow a better aesthetic outcome. And then advances in both the periodontal aspects of tissue manipulation. Maybe we're going to be able to grow tissues in Dappen dishes and add them at the time of surgery in the future. All these will make it more predictable and easier for all of us. Implants in the aesthetic zone can be placed relatively predictable in single tooth situations, or we have 2, let's say, central incisors missing. When we have multiple adjacent teeth missing on one side or on the other side, it becomes increasingly difficult. So the outcome largely depends on initial patient presentation. So if there's adequate bone, hard and soft tissue, then a single tooth implant in general is the best way to go. If there's inadequate hard and soft tissue, it becomes increasingly difficult, and a fixed partial denture or a bridge might be indicated. Or we will have then a combination of implants and bridges in multiple missing teeth. Scalloped implants, implant design is a good design for patients that have adequate ridge morphology, where we have a three-dimensional configuration of the ridge and where we can maintain it. Probably it's still the best implant design if we have to place multiple implants next to each other, although even there we will have an outcome that's not as ideal as on the contralateral side, but it's better than with flat top implants. So in the aesthetic zone with three-dimensional topography, scalloped implants have been shown to increase the outcome as measured by the pink aesthetic score, and there have been recent publications in the Journal of International Peri-Restorative Dentistry where we have significantly better pink aesthetic score as the measurement of outcome. Contraindications is when we have flat ridges, or if we have very inexperienced operators, because the implant location, facial as well as coronal apical, is absolutely crucial for success. The ideal abutment material will depend on a number of factors. If we use a traditional flat top implant, then I think a zirconia abutment is the abutment of choice in the aesthetic zone, and probably placing it at the time of either implant placement or uncovery so as to not further have to remove the abutment would be important. If we use a scallop implant where actually the crown will go on the shoulder of the restoration and incorporate the abutment only as a retentive device, it really doesn't matter whether it is metal or whether it's an all-ceramic abutment. The question of screw versus cemented implant restoration is as old as implant dentistry. But in general, in the maxillary anterior region, because of the angulations or the difference of angulations between available bone and trajectory of the tooth, most of our cases will have to be cemented. Otherwise, we'll have a palatal implant placement. In the posterior areas, cemented restorations are making a comeback as we now go to all-ceramic restorations, and we no longer have the aesthetic drawbacks of the chimneys we saw earlier, the metal chimneys and dark occlusal surfaces. So all things being equal, today I prefer, if possible, a screw-retained restoration just because of the ease of insertion and not having to clean off the cement, or being able to make sure that we clean out all the cement, although in the anterior this still remains an issue.